Hi, I'm Dr. Diniz, and on this video, we'll be talking about cardiopulmonary biomarkers in veterinary medicine. So what is a biomarker? A biomarker is anything that we can measure that will represent the function of an organ or a system. So we use biomarkers every day in vet medicine, and we don't even recognize it. Some of the simple examples that we can think of are biomarkers for liver disease, like ALT and AST, biomarkers for blood, like the red blood cells. We measure them as a biomarker for oxygenation of the tissue, for example. Creatinine, a typical biomarker used for kidney disease. SDMA, the new biomarker that we use now for early kidney disease, and so on. And the goal for veterinary practice and in general for human medicine is to have as many specific and sensitive biomarkers as possible that will represent the function of as many organs as possible. So today we will be covering some of the biomarkers that have been used in cardiology and in respiratory disease as well. So what makes a biomarker a good biomarker? So first of all, a biomarker that we can easily measure, something that will be not too expensive to be able to measure. That is something that is easy to get the sample. You don't want to have to do a CSF tap on a spinal tap just to get a sample to be able to measure a biomarker. And a biomarker that can provide us a good clear cut between healthy and sick, and maybe even help us monitor the progression of a disease. So here are some examples of uses of biomarkers. Diagnosing acute or chronic diseases. Nowadays we have biomarkers even for certain types of cancer. Detecting those subclinical patients that are not yet presenting clinical signs. And some of the species that we work, so for example, cats, are great in hiding their clinical signs until they have overt disease. Stratifying the risk, it means being able to identify those patients that are at higher risk than others for developing the disease or even sudden death. And also monitor the therapy, making sure your therapy is working. Instead of having to do comprehensive workup that might be very costly to the client, imagine a simple blood test that could give us the information if the heart is working well or if the cardiac disease is under control. And also biomarkers that will help us select the best therapy for that specific case. So the focus of today's talk is to talk about the biomarkers that are currently available in the market and on veterinary market in the United States. Biomarkers that have good sensitivity and specificity for the organs that are being targeted, and to expand the content from the manuscript, the review paper that was provided to you as part of the tasks of this course, and to share some of my clinical perspective on the use of these biomarkers. So imagine the dream of having a portable machine by the side of your patient, and you get a blood drop in a cartridge and stick it inside of that device, and you can in few seconds have a definitive diagnosis. Oh, the lungs are affected or the heart is affected. That's the dream for any clinician, any veterinary practitioner. And this is exactly where the future of veterinary medicine is going towards. Nowadays, we do have bedside tests, some lateral flow ELISA tests or the SNAP tests that can give you very accurate answers on given organs being affected. So I'll firstly talk about cardiac biomarkers, as will be the main target of this talk. So because biomarkers, cardiac biomarkers have been very well studied in human medicine, since humans are predisposed to acute myocardial infarcts, there is a series of different biomarkers being evaluated, and they classified based on the mechanism. For example, myocardial injury, myocardial stress, oxidative stress, and so forth. These are some of the categories that human medicine evaluates potential cardiac biomarkers. In veterinary medicine, we have available currently, and this video is being recorded in 2020, two cardiac biomarkers: troponin I, which is a leakage biomarker classified under inflammation, and NT-proBNP, which is a secreted biomarker classified under oxidative stress. So I'll be giving more emphasis on these two biomarkers. So when you think about myocardial injury or myocyte injury, what comes to your mind in terms of what can hurt a heart? So ischemia and different modes of ischemia can be associated with in humans, like coronary disease. In our patients, one of the most common causes is chest blunt trauma, also called the hit by car. But you can think on vasculitis, hypoxia, shock, and the different mechanisms of shock. Over neurohumoral overstimulation, and these are important mechanisms that are part of the congestive heart failure mechanism in dogs, cats, and humans. For example, the chronic release of catecholamines can affect the heart. Endothelin 1, which is one of the markers that was discussed in the paper provided. And angiotensin 1 is a particularly important one as a consequence of the RAS activation, which perpetuates the mechanisms of the congestive heart failure. Some of these hormones will affect the heart. Also, inflammation, overall inflammation. If you have a severe inflammation in one given organ or tissue, that can cause a systemic response to the inflammation, and that response can affect the heart. So we can have antibody response to a given organ or system. And also necrosis and apoptosis. Some specific cardiac diseases have this underlying mechanism as well. So I'll focus now on the marker for myocardial injury, the cardiac troponins. So what are troponins? Troponins are these small proteins that participate in the contraction of the cardiac muscle and the skeletal muscle. They make a complex of three proteins, three troponins. They are labeled troponin I, troponin C, and troponin T. And the reason they are labeled like that is because of the function they participate in the cardiac contraction or the musculoskeletal contraction. So let's take a look here on this illustration. On the top here, we have the thin filament of the muscles, the myofibril in a muscle cell. And this big one here is the thick filament. So if you remember, what are the proteins that participate in the thin filament? The first one, the little white pearls here, is the actin. And they are put together and twisted with the tropomyosin. Now, after that, the three proteins, the thick filament is made of myosin, where you have the myosin head that looks for the specific point to attach into the actin, into the thin filament, the binding site, as we call it. Now, the binding site is hidden during relaxation because of the troponin complex. And the troponin that is on top of that site is the inhibitory troponin, or troponin I for inhibitory. And to be able to move the troponin away and expose the binding site of the head of the myosin, you need the participation of the calcium. So calcium will connect to a troponin named troponin C for calcium. And the troponin C will move the troponin I away, and the binding site of the head of the myosin will be able to attach. The troponin complex is attached to the thin filament by the troponin T because it is connected to the tropomyosin. So here is the troponin T. The C stands for cardiac troponin T. I will explain that in a second. This is the troponin C where the calcium attaches, and this is the troponin I, is the inhibitory. And during the contraction on letter B here, you see how the troponin I moves away from the tropomyosin, from the actin, so the head of the myosin can attach. So in human medicine, troponin I is mainly used to diagnose acute myocardial injury, a typical heart attack. How does that mechanism work? How does that work? So if you have a lesion in your myocardium, those cells start dying and the permeability of the membrane changes. So the troponin complex start leaking into the circulation. As a consequence, you will see a huge spike in the level of these proteins in circulation right after the injury. And several markers have been studied over the years. The previous marker most commonly studied before troponin I came to the place was the creatine kinase, the MB isoenzyme. So it's called CKMB. So we can see here the levels of CKMB in green after an acute myocardial infarct versus compared to the troponin I. That's why troponin I end up replacing, and we no longer use CKMB as a marker for cardiac injury. And the beauty of this marker is that they will have a spike after the acute injury, and it takes hours to few days to get it washed out of the system. So today, if anyone shows up in an emergency room with chest tightness, tingling in the left hand, shortness of breath, they will immediately run a blood test for troponin I as the gold standard marker for acute myocardial injury or heart attack. Now, our patients don't have heart attacks. Dogs and cats rarely, almost never, can develop heart attacks the same mechanism as it happens in humans. So how can we use troponin I in veterinary clinic practice? So we use troponin I because it's a marker for leakage. It means that cardiac cells the membrane is being broken down, and the content of these cells have been released into circulation. I like to think of troponin I like the ALT of the heart. As you might know, ALT is a leakage marker from the liver. So hepatocytes, when they die or the membranes are altered, they will leak ALT in circulation. Troponin I is virtually the same thing. So troponin I, it has additional amino acids on the N-terminal, and this part is important because in the beginning there was a discussion, can I use human kits to test for troponin I in dogs and cats? So after comparing the DNA sequence and the protein sequence, it was discovered that the main part of the protein that is targeted by the diagnostic tests, it's similar between dogs, humans, and cats. The beauty of that you can use human kits and human diagnostic labs to measure troponin I in dogs and cats. The half-life in dogs is 2 to 4 hours, and it spikes between 2 and 8 hours, as I showed in the previous slide. In terms of diagnostics, it's relatively stable in room temperature, but you definitely want to freeze the sample if you take a few days to analyze it. It can, as I said, can be run in a human diagnostic lab, and at least the two major diagnostic labs in the United States offer measurements of troponin I nowadays. As you saw in the paper, troponin T can also be used as a biomarker. But troponin T is not as specific and sensitive as troponin I. That's why you see me talking more about troponin I. And an important aspect is that the amino acid structure of troponin I from the heart, it's different from skeletal muscle. That's why troponin I is so good as the cardiac troponin I. Let me correct that. It's so good as a cardiac biomarker because even if you are hit by a car and you have muscle damage, but you don't have cardiac tissue damage, troponin I, the cardiac version of troponin I, it will not be elevated. So the good point is that troponin I is extremely specific for heart conditions. So the cardiac troponin I is very specific. The problem is it's so specific that other things might increase as well. So the top one cause of troponin I that we see in practice is acute blunt trauma, a dog that falls or a cat that falls for a certain height or is hit by a car, anything that will affect the chest and cause a blunt trauma. But progressive cardiac diseases can also increase blood levels of troponin I. I will show some examples. Other cardiac disease or diseases around the heart, such for example, pericardial effusion, can also cause, or anything that will cause damage to the myocardial cells, like systemic infections, sometimes infections that are not necessarily associated with the heart muscle, but they'll cause a systemic inflammation can cause that, or even chronic ischemia. Very anemic animals, you will see increase in troponin I. And in rare cases, severe skeletal muscle injury because of myoglobin release, and it ends up being toxic too. So this is an interesting case. So this case we published several years ago. The name of this dog is Billy. And Billy was presented in our teaching hospital with a history of being hit by a truck. It's a miracle that Billy survived. And when he was presented, he had double femur fractures. And of course, this animal was in pain. As a consequence, during the intake, we noticed that Billy also had cardiac arrhythmias. But cardiac arrhythmias can be caused by a multitude of things, including pain, including stress. So initially, we believed that that could be the cause. But the type of arrhythmia that he was presenting, it was significant enough for us to pilot, including him in a pilot for measuring cardiac biomarkers. At that time, CKMB was the preferred marker, and troponin I was the new marker being tested. And in this case, we can see that these are the markers after 2 days, 4 days, and 39 days after the traumatic event. And we had a second patient in the hospital that we also measured on day 2, day 6, and day 9. And then we had a loss of follow-up. You can see here that both markers, CKMB and troponin I, dropped significantly between the second day and the 4th day, or the 2nd day and the 6th day. But it's still, and it slowly decreased all the way to the last day that we measure. And an important point that I want to make here is the scale of the increase. Pay attention on the scale on the left side of this chart, from 0 to 25, or from 0 to almost over 80. Those are extremely high levels of troponin I. As you will see, that can be associated with life expectancy. So the troponin, in this case, is right after the traumatic event, both dogs were presented with severe myocardial trauma to the point that specific medication had to be used, and the surgical procedure for fixing the femurs had to be postponed because the risk of these animals dying during anesthesia because of the severe heart condition associated with the trauma was high enough for us to wait for the surgical procedure to happen a few days later. So we put these both animals in beta blockers, a typical cardiac antiarrhythmic medication, and the pain management, restraining a movement because they had major fractures. And once the heart could heal enough and the arrhythmias were under control, then both animals were submitted to orthopedic surgery. In this study in dogs, they also demonstrate that when control dogs, and these are the levels of troponin I in the y-axis, control dogs normally have very low levels of troponin I, but dogs were subject to a trauma, blunt chest trauma, had elevated levels. Of importance here, the gastric dilatation and volvulus syndrome is particularly important and very well described to cause cardiac problems after the volvulus is put back in place. There is a very well-known syndrome called Reperfusion Syndrome because that part of the abdomen that was twisted had lack of blood for enough time to cause severe damage to the cells. When you put that back in place, the recirculation of those organs will bring a wave of toxins back to the heart, and these animals develop severe arrhythmias, and most of them will die because of the arrhythmias after the surgical procedure. So this case shows that those toxins effectively cause damage to the myocardial cells to the point that high levels of troponin can detect in circulation. So the conclusion that troponin I is a great marker for acute cardiac disease. This study in dogs have demonstrated dogs with chronic cardiac disease can also have elevated levels of troponin I. In this case, boxers with a specific arrhythmia called the arrhythmogenic right ventricle cardiomyopathy. This arrhythmia is intrinsic of boxers with a specific genetic mutation in the striatin gene. As a consequence, cardiac cells on the right side of the ventricle will progressively die and be replaced by fat or fibroblasts. So troponin I was detected elevated in a group of dogs with this type of arrhythmogenic disease in boxers, which was higher than control dogs. However, I pointed about the scale of the magnitude. Remember in the previous cases, we are talking about very high levels. In the case that I presented on my paper, it was above 60 nanograms per deciliter, per liter. And in this case here, we are talking about like 0.26. And here's one of the limitations of troponin I. It's that for chronic diseases, the magnitude of the increase, it's low, so low that sometimes overlaps with their normal levels of dogs, makes it hard to interpret. Now, as the diseases progress, as the cardiac diseases progresses, troponin I tends to elevate as well. So in this case, we see dogs with chronic mitral valve disease, which is another name for myxomatous mitral valve disease degeneration, where healthy animals have very low levels. As the disease progresses, the level of troponin I detected in circulation would increase. This is great, but again, the magnitude here, as you can see, is it did not even reach 0.2 nanograms per milliliter of blood, which for some of this lab tests is the cutoff. So again, it's great to detect the progression. However, the magnitude is difficult. So it's not a great marker for chronic progressive disease, cardiac disease. Interesting, this paper from 2016 looking into dogs that were presented in emergency room for different reasons and survival of these animals. So here's the levels of troponin, the levels of troponin, and how many of them actually survived. So as you can see, patients that had lower levels of troponin I at the time they were presented in the emergency and critical care hospital, most of them survived, while patients that had higher levels of troponin I had a much less frequency of survival, which is similar to what is seen in human beings. So very high levels of troponin I means that there is a massive damage to a large number of cardiac cells. So a lot of troponin I is leaking from the cardiac cells to the circulation. So there you can a certain correlation in terms of the elevation of troponin I and the size of the lesion have been defined in human beings. So in conclusion, troponin I is a highly sensitive and specific cardiac marker for muscle injury, especially the acute injuries, because you see a high magnitude of the detection levels in circulation. The levels can be correlated to a certain extent with the amount of the injury. And if you measure multiple times and it does not decrease, it means that the underlying process continues to be present. Some studies in humans have shown that if the levels decrease over time, patients have a better prognosis. If the levels remain elevated or getting higher, the patient has a bad prognosis. Now, as I said, the problem of troponin I is that anything else in the system that might be affecting the body can affect the heart as well. It's so sensitive that extracardiac diseases will also be elevated. This is actually my PhD study where I evaluated the effect of vector-borne diseases into the heart. I would see dogs infected with vector-borne pathogens developing arrhythmias. For that reason, I used troponin I, and no matter what type of infection these dogs had, some dogs had elevated levels of troponin I. In my case, the Ehrlichia canis group, which is a disease transmitted by ticks, the brown dog tick, those animals had statistically significantly higher levels of troponin I than the control group. But as you can see, the other dogs that were sick as well, which we call the non-Ehrlichia canis, because they were sick, in fact, with something else, also had elevated levels. So the take-home message is that it does increase with something else. So here's a recap of the limitations. It has been described in, for example, dogs with pyometria, dogs with sepsis, dogs with other diseases, systemic diseases. Troponin I will also be elevated. For that reason, when you have an elevation of troponin I, you have to make sure you can exclude systemic inflammation, infection, systemic diseases that might be also causing it. And as I mentioned, has little value as a screening for cardiac disease. So it's not a test that like, oh, I hear a murmur, I want to do a blood test to see if this murmur is significant. That you have limited diagnostic value. So the take-home message here is that it's not 100%, is 100% specific for the muscle of the heart, 100% specific, but think of the non-cardiac causes that could potentially increase. Now, let's talk about a different marker. Instead of a marker that would leak from the cells as a consequence of the cells being disrupted, dying, in this case, the cells are under some stress and they will produce this type of peptides. Okay, the natriuretic peptides. It's the next topic. So, as the name say, what are natriuretic peptides? These peptides, they are secreted from the heart muscle to increase natriuresis. In other words, to make the dogs and the cats pee more. And that's the counterbalance when you have the RAS activated. When the RAS is activated, you have retention of salt and as a consequence, you have retention of water. When the heart detects that, you secrete natriuretic peptides, so you can like excrete more sodium and in consequence excrete more water through the kidneys. It's just the balance between the retention of liquid, the liquid and excretion of liquid as part of the cardiovascular system. So there are several natriuretic peptides that have been described in humans and in animals, including ANP, BNP, CNP, even like DNP maybe. And they have been detected in different parts of the circulation. The CNP was originally identified in the brain, for example. The focus of my talk will be on BNP because the BNP is the one that is available through the diagnostic labs in the United States. I know this is a very busy slide, but stick with me because there is one important take-home message that I want to show you. How PMPs are secreted by the cardiomyocytes. They need to be under some sort of stimulus. In this case, normally it's this is increasing volume or stretching of the atria and especially the ventricles. So if you have, if the cells are under a little more stretch, for example, increased preload, or in other words, let me give you a better example. Let's suppose I do an IV fluid in the cephalic vein, but I open really fast. I go on a very fast IV fluid through inside of a vein. That extra volume will go straight to the heart, and the heart will have to adjust for the extra volume. That will cause an increase of the expression of the BNP gene, and the initial protein um, expressed inside the cardiomyocyte, it needs to be secreted and then cleaved in circulation to become active. So the initial protein is called pro-BNP and is inactive until it's secreted into circulation, where it's cleaved into two portions. The active NT-proBNP, sorry, the active BNP, which is this one, and the NT-proBNP. So the NT-proBNP is the inactive portion of the pre-protein. And interestingly, the inactive fragment of the peptide actually has a longer half-life in circulation than the active form. So the active form, which is the BNP, it suffers continuous cleavage by endopeptidases if it doesn't reach the receptors, which are there are different receptors where we will see the effects that we are looking for, that we will be talking later, the natriuretic peptide receptors. The active form of BNP has a much shorter half-life of only 20 minutes in human beings, for example. So that's why we target the inactive form, which is the NT-proBNP, and not the active form BNP, because the half-life in circulation is bigger. So when you draw a blood sample, by the time it reaches the lab, it is still there inside of the blood sample to be detected. Now, BNP has several important functions, as I said. It counterbalances the RAS. And so these mechanisms are particularly important for restraining the progression of congestive heart failure. As part of our learning issues in the development of congestive heart failure, the pathophysiology of congestive heart failure, you should have stumbled upon the fact that the RAS causes systemic vasoconstriction, is a angiotensin II is a potent vasoconstrictor, and this will increase the afterload, so you increase the cardiac workload, and that will cause cardiac remodeling. So remodeling, and when the shape of the heart is changing, so we can start seeing dilation of the heart, and it will also cause this permanent not permanent, but intense vasoconstriction. So BNP and AMP do exactly the opposite. It will cause vasodilation and then it will prevent cardiac remodeling, and it will decrease, inhibit the sympathetic tone. So it has a lot of potential benefits to the point that has been investigated to be used as treatment. And so, as I said here, it antagonizes the angiotensin 2, aldosterone, and vascular remodeling, and also helps in coronary flow. That's why, as I said, has been investigated as a potential treatment. For us in diagnostics, because the protein it's different from humans, the peptide is different from humans, you need to use specific assays. You can use human diagnostic labs. The BNP, as I told you, has a very short half-life. In dogs, is 90 seconds in some literature. So we always want to test for the NT-proBNP. And the test, it's available through the main diagnostic labs in veterinary medicine. Now, which diseases do we expect to see, or we see elevations in BNP? Every time you're going to have more feeling, stretching of the heart. And that's a very powerful diagnostic tool, because when we have activation of the RAS, we have retention of sodium and water. As a consequence, we have increased preload. Every time I see increase in preload, I would see increase in BNP. So BNP is a great marker for how much the RAS is activated and how far down the road of the congestive heart failure mechanisms my patient is having. Unfortunately, other non-cardiac diseases can cause some stretching or stress on the muscle wall of the ventricles. And the most common one is pulmonary hypertension. If the pressure inside of the lungs is high, then the right ventricle have to squeeze harder to push blood towards the lungs. And that mechanism, you end up increasing BNP. Remember, pulmonary hypertension causes effect on the heart, but not the heart is sick. The heart is responding to the high pressure inside of the lungs. Now, natriuretic peptides are excreted by the kidneys. So as a consequence, if you don't have good kidney clearance, then you will accumulate BNP and other natriuretic peptides in circulation. So let's take a look at a couple of studies. This study in dogs have shown compared dogs with respiratory disease other than pulmonary hypertension. So pulmonary hypertension was excluded from this group. Dogs with heart disease and dogs with heart failure, which is different. So what we can see here that dogs with heart disease and dogs with heart failure had a significant higher level, and see the magnitude of the increase is very high compared to respiratory disease. This is why BNP is one of the best markers on the market to differentiate cardiac disease from respiratory disease, other than pulmonary hypertension. So if you are presented that dog with a grade 3 murmur and is coughing, and it's a small dog, and you don't know if he's coughing because of a respiratory disease like collapsing trachea or chronic bronchitis, or because of cardiac disease, because of that mitral insufficiency and a murmur. BNP does help a lot in this case, being able to differentiate those two. Next one, it also is available diagnostic tool in cats, where cats with heart disease or congestive heart failure also were detected with higher levels compared to normal cats. So it does discriminate well in both species. And it is associated with survival. So in this study, dogs with mitral valve disease were followed for several years, and the levels of BNP at presentation were measured, and then the populations were divided. And patients that were presented with low BNP survived much longer than patients that were presented with high BNP. So it's a good tool for monitoring survival. And you can use to monitor therapy. as long as you have significant changes from one measurement to the other, and some papers talk about like changes as high as 60% on the value, it will give you a good information if your therapy is working. Now, as I said, BNP is excreted by the kidneys. So in this study, it just confirms what I told you, where a dog, so in this left side of the screen, this is dogs with different diseases and the level of creatinine, which is a marker for renal function. As you can see, healthy dogs, dogs with heart disease or congestive heart failure, all had low creatinine, but dogs with azotemia because of chronic kidney disease had high levels of creatinine. Now, these dogs, the same dogs, were measured for troponin for BNP. And as you can see, the healthy dogs had lower levels. Dogs with congestive heart failure had high levels, but dogs with chronic kidney disease overlapped with the population with heart disease or congestive heart failure. So that's why you always have to rule out dogs that have low GFR or have any type of renal disease. As I mentioned then, pulmonary hypertension is one of the important things we need to rule out, and pulmonary hypertension is hard to rule out. As you read on the paper, we still don't have a good marker that has high sensitivity and specificity for us to rule in or rule out pulmonary hypertension. The gold standard for diagnosing pulmonary hypertension remains echo Doppler cardiography if the patient has regurgitation in the valves of the right side of the heart. So it is a expensive diagnostic test. Is not easy to do. Not every veterinary practitioner can do this test and require training. That's why we hope in the future we could find a better marker for pulmonary hypertension. There are some signs of pulmonary hypertension you can find in chest rads, but normally these patients have to have like an advanced, moderate to advanced stages of the disease. Remember, BNP is not a good marker for acute injury. If you're suspecting a patient to have acute cardiac problems, like, as I said, hit by car or gastric dilation and volvulus, then you definitely want to use troponin I and not BNP. And make sure you always check the renal function. So as a conclusion, is a great marker for chronic progressive cardiac disease. Is even for my dog, she's not here, I have a 7-year poodle that, of course, as a poodle now has a grade 3 murmur. And she has a murmur. I did chest rads, everything looks normal. I did echocardiogram and everything looks normal. But I really wanted to make sure if the RAS was start getting activated, because then it's time to start using medication to control that. Remember, the RAS activation is one of the important perpetuating factors of congestive heart failure. And in her case, her measures of BNP were within normal range. So I am monitoring her and I'm remeasuring these every 4 or 6 months to see if they would spike. If they have a significant increase, it's time to start medication. Now, let's shift gears and talk about D-dimers. So D-dimers are not specifically markers for respiratory disease, but in the context of the case of this week, we would like to talk about them because they are excellent markers for intravascular coagulation. So what are D-dimers? So D-dimers are specific fibrin degradation products. And this is my best attempt to try to explain where they come from. So I know it's a busy diagram, so let's try to walk through it slowly. So on the top here, we have fibrinogen, and during the formation of a clot, fibrinogen, you will become cleaved by thrombin, forming fibrin. And the fibrin will form a mesh where the clot will form. So it forms this fibrin polymer that exactly it will keep the clot stable. Now, the fibrin has these D domains that are highlighted here in orange. And when the factor 13 is activated, it forms cross-links between these D domains of the fibrinogen molecule. Once it's formed, so to keep the molecule as stable as possible. Now, with time, plasmin will start breaking these clotting pieces, which is the normal cycle of formation and degradation of clots. And once plasmin start breaking them, you form these fibrin degradation products that we measure as a biomarker of coagulation. And this specific cross-linked domain, this antigen, is formed that we call D-dimers. The beauty of this antigen that we call D-dimers is that we can target it with specific monoclonal antibodies and make a very sensitive and specific diagnostic tool. And that's the reason that we use D-dimers as a marker of coagulation. So the beauty of the dimers is that they are very specific for fibrinolysis. They indicate that thrombin was generated and plasmin broke the clot and formed these peptides. So as a consequence, it's an excellent marker for intravascular coagulation. In human beings, is one of the gold standard markers for example, pulmonary thromboembolism and deep vein thrombosis. In veterinary medicine, we don't see deep vein thrombosis as frequent as in human medicine. However, pulmonary thromboembolism was always a difficult diagnosis before we had the dimers available to us. So what are the advantages of testing for D-dimers? Because they are a marker for thrombosis. Your patient is forming clots inside of the circulatory system. They might be having thromboembolism. These clots are moving, getting dislodged, and they may be causing a thrombus. They may end up in the lungs, causing pulmonary thromboembolism. They might end up going to the brain, causing an ischemic event. They might end up inside of the kidneys, causing kidney infarct and acute kidney disease. And in animals, if the level is above 1 nanogram per milliliter, that is particularly sensitive for thromboembolism and disseminated intravascular coagulation, or DIC. It also has been used as an indirect marker for hypercoagulability, which is some different diseases will bring the patient to a state of forming clots more frequently than normal. And they are in this constant mechanism of forming clots and dissolving clots, even though they might not even have clinical signs yet. So D-dimers are a good tool for detecting patients on that. And some types of cancers are examples of bringing patients to a more hypercoagulable state. Other examples is when the patients have chronic proteinuria, when they will be losing proteins that are associated with the anticoagulation in circulation. So as every other marker, what you're seeing that they have the advantages and they have the limitations. So the limitations of the D-dimers is that they are formed because you're having fibrinolysis of fibrin, so fibrin degradation products. So who tells you that you can only have a clot in your veins? Or I hope you don't, but clots, intravascular coagulation. If there are bruises or hemorrhages, can be tissue hemorrhages, can be hemorrhages to cavities, or we call cavitary hemorrhages. Those will also, of course, elevate the levels of D-dimers. Also, because if you have fibrinolysis because of wound healing, that can also increase D-dimers, as well as some types of cancer, because you have fast growth tissue. And because D-dimers are broken down by the liver, then if you have liver dysfunction or liver insufficiency, let's say, then the dimers will be artificially elevated because you're not having enough clearance. Now, let's change gears again and talk about acute phase proteins. And the emphasis will be in C-reactive protein. So what are acute phase proteins? So acute phase proteins are proteins that are um, produced by the liver as a consequence of a stimulus coming from pro-inflammatory cytokines. As you might know, the most common pro-inflammatory cytokines is interleukin 1, interleukin 6, TNF alpha, and these will stimulate the liver to produce a series of proteins. And the liver is so busy producing acute phase proteins, then you can actually see a dip on albumin, which is the most common protein found in circulation and exclusively produced by the liver. So when you see a drop in albumin in acute infection, is because the liver is busy trying to produce acute phase proteins. So some of the proteins that can be detected include the C-reactive protein, which is an acute phase protein for dogs, but not for cats. The serum amyloid A, which is a good marker for both dogs and cats. The alpha-1 acid glycoprotein, which is a good acute phase protein for cats, but not dogs. And fibrinogen, which is not normally used for dogs and cats, but is also used in other species such as horses. What are the advantages of measuring acute phase proteins as biomarkers? They are very sensitive for inflammation in general. For example, C-reactive protein has higher sensitivity than white blood cells and differential counts for inflammation in dogs. However, and it can both detect the symptomatic patients and the asymptomatic patients. So if you suspect of inflammation and infection, it's a great marker. It would spike earlier than white blood cell counts. And if you see a progressive decrease over time, it means that the inflammation is decreasing. So it's a great marker to follow up during therapy. However, it never tells you where the inflammation is. And that can be particularly difficult because with the C-reactive protein and other acute phase proteins are stimulated from a variety of mechanisms. So we include infection, inflammation, endocrine disease, neoplastic disease, GI disease, and that can be daunting to be able to parse what is causing it. So when we test C-reactive protein, for example, if it's elevated, we know the inflammatory system is activated. Unfortunately, we don't know where it's activated. Remember, these are in response of inflammation. If we have something in the system that is suppressing inflammation, that will be a problem. So imagine if the patient has received glucocorticoid therapy, that will inhibit the inflammatory response of the patient. So you will be artificially decreasing patients receiving glucocorticoid therapy. Or if this patient has endogenous high levels of cortisol, such as in case of Cushing's disease, the inflammatory response will be lower. Therefore, the acute phase proteins will also be artificially low. And in end-stage liver failure, the liver will not be able to respond fast enough to produce acute phase proteins. So in liver disease, they might be artificially low as well. So this talk was about some of the markers that we use for cardiac disease or respiratory thromboembolism. We talk a little about inflammation. You notice I didn't talk about all the markers that were listed on the manuscript because those are not, or they are not available in the veterinary market from the main diagnostic labs, or they don't have good sensitivity and specificity. But the markers that we discuss are just the tip of the iceberg, especially in cardiology, where several Dozens of different biomarkers have been evaluated, and we hope that we're going to have more specific biomarkers for specific cardiac disease, such as the progression of mitral valve disease and so on. So I hope this talk was helpful. As always, you can find more information about this topic on Blackboard in the small animal medicine folder. I created a little corner for myself on Blackboard where you can learn more about ECGs, you can learn more about echocardiogram, you can learn more about biomarkers. I also posted another review paper there specifically about cardiac biomarkers. If you got confused about something on this talk, that paper is from where I based most of this talk about troponin I and about BNP. So thank you very much and see you next time.